So I move a lot when I talk, so sorry if that bothers you. Also want to preface this with the fact that this is a whole lot of information that I'm cramming into 15 minutes, so if it seems rushed, that's why. So there's more information for you on the tables out in the hallway if you want more information on the program I'm talking about, okay? So this is the evaluation of a Youth Emergency Room Enhancement Program for Behavioral Health. We call it the Youth ERE program. So just to give you a sense of the problem that I'm kind of touching on today. So between 2 to 5% of pediatric emergency department visits are for behavioral health reasons. And recently, there's been a 42% increase in behavioral health ED visits for pediatric patients in Missouri. Additionally, in St. Louis City alone, just for adolescents between 13 to, 17 years old? Oh crap, I'm on the wrong slide. Sorry, my bad. What was I saying? St. Louis City alone, adolescents, in 2014, there was over 17,000 youth who had a serious behavioral health problem that affected their functioning, okay? Remember that number. That's a significant number for a city, right? Okay. So the project that I'm talking about, this Youth ERE program, was done in this eastern region of Missouri. So these 7 counties listed here has a population between, it's 2.12 million people in that county, and that includes rural, suburban, and urban populations. Between 21 and 25% were below 18 years old, so we're talking about our pediatric population. Many of them living in poverty, depending on the area that they were living in. Looking at the hospital facilities, in this 7-county region, there are 30 hospital facilities with a total of 821 psychiatric beds. 5 of those facilities had pediatric beds, so we're talking about child or adolescent or both, okay? That's less than 100 beds for our pediatric patients needing behavioral health care at an acute level. Now, if you go back to that 17,000 youth with serious behavioral health issues in St. Louis City alone in 1 year, does that seem sufficient? It's not, right? Where do those patients go to get help? They go to the ED. Right? They're going to the ER for behavioral health care. They're going crisis to crisis, right? So this program is aimed at helping reduce that, okay? So, goodness gracious, thank you. So the Youth Emergency Room Enhancement Program, or the Youth ERE program, is intended to be a short-term intensive outreach program. So we're looking at 3 to 6 months time for those high-risk, difficult-to-engage youth who have trouble engaging in traditional mental health services. They're not going to a provider, they're not going to a community mental health center, they're using the ED for the behavioral health care, okay? It's for 6 to 18-year-olds. We took up to 20-year-olds if they were still in high school, okay? High risk meaning they have a significant behavioral health need. It could be a first instance of it, or it could be a chronic issue. It could be behavioral health as in a traditional mental health diagnosis. It could be a substance use. It could be a combination, okay? The goal is to identify and minimize barriers to getting into care, whether that's traditional, a doctor, or a community mental health center, okay? So the program is actually done by social workers, and so what happens is a social worker actually goes to, one of the case managers goes to the ED. So a patient is referred from the ED or a medical floor or an inpatient unit, is referred, goes, the social worker actually goes to that patient, okay, in that moment while they're in crisis and says, okay, you meet criteria for this program, do you want to participate? Yes, I do. And they start right then, in the moment, identifying the barriers to care, and they have intensive case management. That could be once a week, that could be 3 times a week, okay? They also have peer support specialists, which is a specially trained parent of a child with severe mental health issues, and they're there to help care for the parent and help teach the parent, how do you care for this youth with mental health needs, okay? A lot of our parents don't know what to do or they have their own mental health issues, right? So we have a peer support specialist, because you can't just care for a kid. You care for the family, right? That's the reality of working with pediatrics. Okay. I make this slide to show how many people are involved in the care of one kid. We have the school, we have the court system oftentimes, we have the community like the YMCA, the parks, we have all the different pieces of the mental health system, we have the family, okay? We wanted to have as many of those stakeholders at the table as we were designing this program, okay? So the purpose of this evaluation that I did was to really look at the pilot year, so the very, very beginning of this program, and was it effective, and how can we make it more effective moving forward? So it was baseline data, it was looking at what change are we making, and what can we do to improve it, okay? So the questions I was looking at, so for this population in this region with this program, we looked at data 3 months before they were enrolled in the program and 3 months after they were enrolled in the program, okay? I wanted to know, was there a change in the number of ED visits? Was there a change in the number of inpatient psychiatric admissions? What was the most common diagnosis? What are we seeing? Who needs this care? And what was the rate of admitted or documented substance use? Not saying they have a substance use disorder, but saying that there is a substance use comorbidity of some kind. I did a thorough lit review, and that helped guide and facilitate the program development. The only program that I found that was similar to this is in Australia. It's called the IMYOS program. There's very little literature, especially in the United States, about youth mental health programming. It's just not there. And so this program was as close as I could find. So we took some best practice pieces of that program and incorporated it into the youth ERE program, okay? So some of those being having a caseload of 6 to 8 patients maximum for our caseworkers. That was really key. The reason for that is that they can have those really strong therapeutic relationships with the patient and the family, okay? We wanted to look at having a longer period of time to collect baseline data, because how many of you work with adolescents or know adolescents or have adolescents? Anybody? Yeah. Are they willing to open up real fast? Man. So we said, so the research showed have a 6 to 8 week timeline to get baseline assessment done. Our program isn't that long. It's intended to be 3 to 6 months. So we said move it to 2 weeks. So we give our caseworkers 2 weeks to get that baseline data and really develop that rapport. The other key piece was providing voice and choice in their treatment and meeting them in non-stigmatizing locations. If that patient loves to play basketball, go on the basketball court with them. So the case managers are going to Dairy Queen, they're going to the library, they're going to school. You're not making the patient come into an office where they're uncomfortable or stigmatized. Okay, that goes a long way in developing that rapport. This is just a brief view of kind of the project timeline. If you can see the enrollment date, for an example, February 1st. We're getting data all the way back to November 1st, all the way out to April 30th, okay? 3 months post and 3 months before. So our project sample, the convenient sampling, from one of these 8 referral sources. How many of you, by show of hands, work at any of these facilities? Oh, a lot of you, good, so this is relevant to you, awesome. Good. So these are our referral sources. So all of our patients in this program come from these sources and these sources alone. For the time being, it's going to stick with that until we get more funding to expand the program. So if you're not at one of those facilities, I'm sorry. You can't refer patients, sorry. Again, 6 to 18 years old, up to 20 if they're in school, significant behavioral health or substance use issue, reside or present homeless in one of these 7 counties, are not currently already engaged in a community mental health center, unlikely to engage in traditional services, and we targeted enrollment for youth in foster care or had open children's division cases, because research shows that those ones are going to be highest users of the ED for the behavioral health care, okay? And the exclusion criteria is the opposite, okay? All right, so I did a PDSA, or Plan, Do, Study, Act kind of cycle for this study. The planning really was, we got as many of those stakeholders at the table for a monthly steering committee meeting. We had people from Children's Division, Missouri Department of Mental Health, every single referral hospital, all 5 of these community mental health centers. They dedicated one staff person to be the case manager for this program. So this isn't a company running or an organization running a program, it's a community running a program, okay? So this is a community program and lots of people are involved in it, okay? So all 5 of these, does anyone work at any of these places or have patients that go to these facilities? A lot of these are for lower income patients, so a lot of them are federally qualified health centers. Regardless, the point there is, it's not one organization running it, it's a whole community put together, okay? We use the literature review to determine the direction of the program design. Sorry, go back. Okay. I already mentioned a lot of this already, so I won't go over it again, but just that the case manager meets the client or patient in the ER or in the inpatient or medical setting. They start that baseline assessment. They also then do a 30-day follow-up assessment and a 3-month assessment. Wow, I have 3 minutes. Holy crud. Sorry, I'm going to fly through this now, okay? Next. Study. I collected all this data. Okay, important being pre and post inpatient and ED admissions and how many days they were in the program. Thank you. Next. Descriptive statistics. Because this is preliminary data, my N was only 24. Those were the only patients that had reached 3 months post. Mean age of 14, youngest 7 years old, oldest 20. Race and gender breakdown was equivalent or was generalizable to the area where these patients were coming from. Housing status, the thing I found interesting was 13% of these patients presented homeless. That's significant, okay? So another interesting one here is that 71% were Medicaid patients. Now, this was not an eligibility criteria. It was just interesting to see, so what is Medicaid for? It's for low-income patients, right? And another 8% had a Medicaid application on file. So a lot of our patients that are using the ED, high risk, difficult to engage, are low-income patients. Most common diagnoses: major depressive disorder, other, which was a lot of the first time we don't have a diagnosis yet patients, ADHD and PTSD. 41.7% had at least 2 diagnoses. Most common substances: marijuana and alcohol. 41.7% of participants had a comorbid substance use. Okay. This was, again, in the beginning, so you can see at St. Anthony's Mercy we had a champion that was really like, send them, send them, send them, right? This data has since changed as the program continued, which is great. Holy crud. Okay. Faster, faster. Push. Okay. Pre-data, okay, where they all were. You can see a lot in the rural areas, some pockets in the city. I did a paired sample t-test and a Wilcoxon-Rank test. Not statistically significant, but clinically significant. You can see it is decreasing pre to post. Okay, that's important. I did a multiple regression analysis. Basically, can we predict who's still going to be a high user despite the program? That was the point there. The regression analysis was statistically significantly predictive. Zip code was the only factor that was predictive on its own. So there's some factor, there's some social determinant of health factor at play in those zip codes where there's still high users. It could be poverty, transportation, any number of things. So, 42.55% decrease in ED visits, 12.5% decrease in inpatient psychiatric admissions. We already talked about the disorders and the 41.7% with substance use. Limitations: small sample size. I plan to do this again as soon as all of the pilot year patients have reached 3 months post. There were time constraints to data collection. Basically, takeaways. The study, oh, are you moving me forward? Okay. I have like 3 left. Okay. Basically, biggest takeaway. Let's just move forward. Program's working. You can see decreases. Those were the highest zip codes. We are now using zip code as a red flag. So for future program participants, if they flag in one of those high-use zip codes, those patients are going to need more resources, right? So we're having more intensive outreach programming for those particular zip codes to improve the quality of care for those patients. Make sense? We're going to continue studying it. Here's how it applies to you. If you work in any of those hospitals that you raised your hand for, you can refer patients to this program. There's an adult version of it on the table in the hallway. There's information on the youth and the adult program. So feel free to take a page. Gives you all the information, all the contact information. Sorry that was rushed. That's all I got. So, we're good?